Hi everyone, welcome to this roundtable discussion on biopsy practice. We'll just have a minute or so for people to join, and then our esteemed colleague, Dr. Austin, will do some introductions.
Thank you, also esteemed Dr. Morrow. I think I'll kick off. Actually, we've got quite a few people that have come in, and just while people are continuing to come in, we'll get going. Thank you so much for joining this genomics webinar this afternoon entitled Boost Your Biopsy. We're just continuing to let the delegates into the waiting room, and we'll start this webinar shortly. So it gives me great pleasure to welcome you this lunchtime to this webinar on the topic of embryo biopsy entitled Boost Your Biopsy. Today we are pooling together a diverse group of industry experts' knowledge, and we'll be exploring current practices to optimise the technique of embryo biopsy. So joining us from Cooper Surgical, we have Dr. Sarima Biswas-Shivar. Sarima has a PhD in reproductive and vascular biology. She is a HCPC registered senior clinical embryologist and a diplomat of the Royal College of Pathologists. Sarima joined Cooper Surgical Fertility Solutions earlier this year as a clinical application scientist, where she provides teaching, training and troubleshooting for IVF laboratories in the UK and Ireland. We also have from Cooper Surgical, Dr. Dave Morrell. Dave has been a clinical embryologist since 1986. In his role as Director of Clinical Support at Cooper Surgical, Dave is now primarily involved in training and education, quality improvement and laboratory assessments, troubleshooting and laboratory design. And also today, I'm pleased to see we've got a whole veritable feast of people joining us. So we've got lots of biopsy practitioners here today, starting with Sharon. Sharon Corcoran has joined us. Sharon has extensive experience in the field of assisted reproduction in Ireland. She has completed an international master's degree in the biotechnology of human-assisted reproduction and embryology, and works at the National Institute of Reproductive Genetics at Beacon Care Fertility. Sharon has a vast embryo biopsy experience, which we'll be tapping into today. We've also got, I'm very pleased to say, Katie Finch. Katie has a degree in medical genetics and a PhD investigating genome organisation and pre-implantation genetic diagnosis. With almost 20 years experience in embryology laboratories across London, and in her role as lab manager and person responsible at TFP Simply, Katie is well placed to share a valuable experience. We've also got Emma Whitney with us today. Emma is the laboratory manager at the Evewell Clinic in London. With over 20 years of practical IVF laboratory experience, Emma specialises in pre-implantation genetic testing of embryos, with a passion to prevent the transmission of inherited genetic disease and enhance the capabilities of embryo selection. So great to have you here with us, Emma. And we've also got Davina Hume is with us today. Davina has worked as an embryologist for over 20 years and has experience of working within both private and NHS clinics. Davina is currently a state-registered senior clinical embryologist at Jessup Fertility in Sheffield and leads the PGT programme for embryology. She is an associate lecturer with the University of Sheffield as part of the MSc course in reproductive sciences and became a member of the ARCS Executive Committee this year. So thank you very much, Davina. And thank you all for joining us. There's a huge amount of knowledge and expertise with us today. So this is a great opportunity to ask lots of questions about biopsy. So please do take advantage of this to ask all these questions. Questions should be submitted into the Q&A box, and we'll answer as many as time allows. Also, I've got a request that if you are an attendee joining us today, if you could please if you mute yourself and switch off your camera, that'd be appreciated as well. Thank you very much. Sarima, Dave, I'll hand over to you two.
Right, thank you, Emily, for the introduction. So what we'll do is we want to keep it really interactive and informal. So we would like to have our presenters or our KOLs who are really experienced with regards to biopsy and in general embryology do most of the talking, and Dave will be asking them the questions. And what I'll do is, before we start, I just wanted to mention that when we discuss each of the questions, and for part one, as you have probably noticed, that we have kept it up to the biopsy technique, because we have a part two coming up, which will deal with tubing onwards. And so for the part one, we will be asking our KOL specific questions and yourselves as well. So we'll start a poll for each of the questions for you to answer as well, while the KOLs are giving us their views. And what we have done here is, while we were doing all the organization and talking about all the different biopsy practices, we've done a joint survey with ARCS, and so we are going to use some of the results that we have from the ARCS survey of the same questions that we are, or the topics that we are discussing today. So before we go ahead, I'm just going to give a quick sort of update on the demographics that we have from the survey, so that you know what you are looking at as we go into the results. So we've got obviously majority of the people who have responded to our survey. As you can see here, 45 out of 54 are from England. We have a couple from Scotland, one from Wales, and we have 6 from the rest of the world. And you can see in the graph below that a majority of the respondents are actually part of an international chain of a private clinic. And then you can see that sort of we've got a mixture of private clinic, which is a standalone private clinic, and public clinics as well, so NHS and so on. And we have a small chain, which are private clinic, part of a national chain. And of course, because we are discussing biopsy today, we thought it would be good for us to know what the usage of the different PGT techniques are amongst our respondents. And as you can see here, obviously not surprisingly, majority of them use the PGT-A. And then we have, of course, 81% and 77%. So really, it's a good mix of all the 3 techniques that are used or are in practice from the people who have responded to the survey. So with that in mind, it brings us to our first topic of discussion, Dave.
Thanks, Rima. So we're going to talk initially about when we do things. And what we want to think about initially is when we do the assisted hatching. So I'm going to kick off with the group and say and ask which days you do the assisted hatching in preparation for biopsy. And simply because of where you are on my screen, Davina, I'm going to come to you, what your preferred day of hatching is.
So currently we do day 3 hatching. The reason for that is there's a nice clear space between the cells and the zona, so it feels safer to do it at that stage. And then we leave them to hatch and biopsy day 5, 6, 7 occasionally. And if they're not hatching enough on day 5, then we'll just culture for longer. And if it's hatching where the inner cell mass is, then we will change our biopsy technique so that we're avoiding that area.
And Emma, Katie, and Sharon, do you do anything differently? Are you all day 3, or has anyone got an opinion on a preferable day? Emma, you're shaking your head.
I don't hatch.
You don't hatch in advance, and you just.
I don't hatch at all.
Okay, so you just breach the zona at the time of biopsy.
Yeah, so we would.
Yeah, go on, Emma.
So we would leave them until they're at least advanced stage 4. If you're Gardner grading blastocysts, we would then laser assist like a collapse, but we would be holding the embryo to allow that to happen, and then we breach the zona and just do the whole thing through one hatching point, one laser point.
Okay, and
yeah, so we're very similar to Emma. Definitely the smash and grab technique, as we like to call it. We only want to be getting those embryos out. Our opinion is that we only want to be getting those embryos out when we need to. We don't want additional procedures. We don't want additional lasering or relasering.
Okay.
Yeah, same technique as Emma.
And Sharon, what is your approach, like Emma's and Katie's, or like Davina's, or something completely different?
More similar to Davina. So we would hatch on the evening of day 4.
Okay.
So ideally using the Saturn V laser. So we would do increased number of small holes into the zona as opposed to larger holes. And we could go as wide as the thickness of the zona. So just to do it once, give it one nice lasering on the evening of day 4 to be ready, hopefully the following morning then for biopsy.
Okay, so just picking up on those differences then. I'm guessing the earlier hatching is because it's somewhat easier. And as you said, Davina, you avoid any laser shots near the blastomeres. And I'm sort of interested around the potential to be doing the biopsy procedure a little bit earlier if you hatch on day 3 and day 4. If you start to see herniation, is there a tendency to then do biopsies a little earlier with fewer cells in the trophectoderm? Would that be a concern, or do you not see that as an issue?
It is a concern because we want to make sure that the biopsy that we take there's enough cells there. If we feel that it's too early and there aren't enough and we want it to herniate more, we just culture for longer. If they're good quality, they will hang in there and be suitable the day after. So we are aware that if we're doing it too early, we might not have enough cells there. So it's not a concern, but you do need to monitor and make sure that the biopsy sample you're getting is enough cells.
And when the inner cell mass is at the point of hatching, I guess this is particularly for Davina and Sharon, how do you manage that? Is it a case of making a second hole, or do you wait for it to hatch? Or
I suppose it would depend on the embryo as well, but no, I wouldn't make a second breach. I wouldn't breach the zona somewhere other than where you made the first one. If it was day 6 and you were kind of running out of time, I would extend the breach you made at the first breach, and you could go at it that way. Or if it was day 5, you could leave it overnight and let it hatch out a little bit more, so you'll have more trophectoderm cells away from your inner cell mass.
Okay, and similar for you, Davina, or do you?
Just wait longer. Yeah.
Okay. Okay, so we've got two sort of camps when it comes to the assisted hatching. What about the? I can see on the poll that there's a mix of day 3, day 4, day 5, and possibly a majority looking towards doing the hatching at the time of biopsy. The biopsy itself, so you hatch either in advance or at the time, and then for the biopsy itself, are you all aiming ideally to do your biopsy on day 5?
Yes. Yeah, that would be the plan, to
Yeah.
try and get as many on day 5 as possible. Yeah.
Does anyone have?
No.
Okay.
I think Emma and I are going to say the same again. So for us, we're led by the embryo, and we will biopsy when the embryo expanded substantially.
Okay, so if you're leaving it potentially to late day 5 or even into day 6, I guess,
7.
or even day 7, is that dependent purely on expansion stage, or do you look at the number of cells that you think you're going to be able to take?
I suppose it's all of those factors. It's so dependent on the embryo. You want to make sure you go at it once, I suppose. You don't want to fail at your first attempt. So you can wait a little bit, and you can see if the nice healthy cells are herniating, and you can always go into the embryo a little bit. It depends on everyone's confidence and expertise in how comfortable they are manipulating the embryo, but you can always go in and just pull a few extra cells out, just to get the biopsy done on the day 5. I'm not against biopsying on day 6 by any means, but we find our success rates are a little bit better if you can biopsy on day 5 as opposed to day 6.
Is that a general view? I'm thinking of Katie and Emma, because you'll take the biopsy whenever it suits the embryo. That's the sense I'm getting from your responses. Is that a fair summary of it?
Yeah, so you're waiting for the embryo to be at an advanced stage because they are easier to biopsy. The zona is thinner. You have pure viability on the embryo that's not going to arrest at the early blastocyst stage. You're also dealing with an embryo that's potentially 150 to 200 cells rather than an early stage herniating embryo that's only at sort of 80 cells. So by leaving them to expand, I don't see, you definitely see obviously embryos that reach the blastocyst stage earlier have more compatibility with pregnancy and euploidy. That's a given. But technically, leaving an embryo to advance, from my opinion, makes it much safer on the embryo, and they do retain themselves inside their shell when you freeze them.
And when you say a more advanced blastocyst, Emma, what sort of thing are you looking for? Is there a particular, if we use the sort of typical Gardner blastocyst grading, what sort of grade of expansion are you looking for?
We won't touch anything before it's a 4.
Okay. And Davina, what your approach, because you've already got the embryo potentially hatched on day 3, is it similar? Do you leave it as long as you can, or are you more are you more led by how it's hatching because you've already done it, if you see what I mean?
Yeah, all of those things.
Okay.
Definitely depending on the embryo and the stage it's at, because obviously we need it to be herniating quite a bit and there's enough cells to take. We do our ICSIs quite early, sort of late morning, so we find our day 5s might be a bit more advanced than some people's who do them late afternoon. But it's definitely led by the embryo. We want to make sure we can take enough cells and there's enough healthy cells there. Or if the inner cell mass is hatching and we feel giving it more time will help with the biopsy technique, then we'd wait to day 6.
Okay, so there's a tendency to try to do the biopsy on day 5. It's led by the degree of expansion. There doesn't seem to be too many concerns about going to day 6. Sharon, you said you prefer to do it on day 5 where you can because you feel you get better outcomes. That's broadly in some consensus. How do you feel about day 7 biopsies? I think Emma, you said you were happy doing day 7. So what's your approach to day 7 blastocysts, Emma? Would you leave everything you haven't already biopsied to day 7 and make a decision, or is there a different approach?
We tend to assess the embryos in the cycle from the end of day 6. If we think there's something still with potential that looks of reasonable quality, we will keep it till day 7. We have probably a bit more of a higher expectation of what we will and won't biopsy on day 7. I'd like to see them at BB and above. We'll biopsy anything on day 5 and day 6 as long as it's viable and expanded. But on day 7, given that from experience at the EVWell, we've probably biopsied about 300 day 7 embryos and 20% of them have come back as euploid. So we've done a little bit of work on that, and we noticed that the quality definitely has an indication for that. So we will be a bit more harsher on what we will and won't biopsy on day 7.
Okay. Does anyone have a different approach to day 7? Does anyone not do it?
We don't culture till day 7. It was trialed a while last year, the year before, throughout the group, and just found the embryos weren't surviving, they weren't biopsying, we weren't getting the results to warrant culturing on an extra day. So we would cap it at the evening of day 6 for biopsies.
Does anyone do anything different? Katie?
No, it sounds like the EVWell and TFP have very similar SOPs. So again, we wouldn't be keeping cells that were still very poor quality or at the cleavage stage to day 7. We'd only be tracking those that had really good potential, and we're looking at that Gardner grade BB or above, preferably. There's a little bit of crossover. We've got a lower cutoff for freezing in our group. We freeze from grade C or above, which is a little lower than some units. So we would consider grade Cs on day 7, but we want to do them as soon as we get in the morning and get them done as quickly as possible.
Okay. Anything different, Davina?
No, we're open to day 7. We don't do it very often, but if there was something that we thought had potential, then we would culture to day 7, but would expect it to be good quality.
Okay, we'll revisit this because we'll talk about criteria for which embryos are biopsied again. So we'll come back to this a little bit more. Just one quick question regarding the day 7. if you're using single step media and maybe using time lapse, do you modify your culture conditions for biopsy cases, given the fact that you're probably extending the culture period an extra day or two? Does anyone modify their technique at all?
I don't think I understand the question. We don't, all our patients are cultured to day 7 if they've got viable embryos, regardless of their, is that what you mean? Do you change it just because they're from PGTA cases?
No,
Yeah,
as in,
well-
I think, do you mean, Dave, you change the media, as in you alter the media on
Yeah,
day
so
5?
so given the fact that
They're
most
going
of
to
the
day
data for single step media is up to day 5, we know that in some labs what they do when they know that they intend to do PGT and they might be biopsying on day 7, they add in a refresh step that they wouldn't do for routine cases. And I wondered whether, Emma, you certainly don't, Davina is
So
shaking
we
her
have
head.
that option. We have that option available, but we make our culture dishes on the morning of the egg collection, which is one of the reasons I like to get the biopsies done as early as possible on day 7.
I know that's interesting in itself.
Yeah, we'll culture up to 6 days, and we've got the data for that. We've got a little bit of data recently to say that the pH was holding beautifully into late day 7. So we're happy with our culture systems in that they can maintain the embryo up until certainly the morning of day 7. A little bit of practice data showed it was fine right into the afternoon as well.
Okay, right. All right, so the poll shows that virtually everyone's doing day 5, with a small proportion doing day 6, and nobody's said they're doing day 4 or day 7. Do you want to show the next?
Yeah, I was
slide,
just going
Susan?
to say that. Yeah, shall we go? So I'm just going to present the survey from the survey results from ARCS. So as you can see that in terms of assisted hatching, we have a mixed, and just want to make sure that you get the results correctly. So these are the number of responses. And of course, given the question here, that, you know, when you perform assisted hatching, as you can see that we may have multiple answers from the same respondent. So we have approximately equal for day 3, day 4, and some obviously at the time of biopsy. And with regards to performing the trophectoderm biopsy, of course, again, as you can see from the number, although we had approximately 54 people who answered the survey, some of them skipped some of the results, some of the questions, but in this case, you can see about 45% of all the responses that we have had said that they preferred to do trophectoderm biopsy on day 5. Of course, then they would do on day 6 if there were embryos available. So that's kind of what we discussed today, and it kind of seems like we're all on the same page on that, isn't it, Dave?
Yeah, I think so. Yeah. So let's move on to how we prepare the environment. I'm going to do this quickly because I want to concentrate more on the embryo selection and technique. So in terms of the environmental preparation, we asked in the survey what you use to decontaminate the work areas for biopsy and tubing. So I'm going to make an assumption, and it is an assumption of our 4 experts, that you are probably using an embryo-friendly cleaning agent. Nods all round. So you would firmly be in the non-embryotoxic IVF disinfectant. You don't use UV.
We do. We do.
You do. Okay. So that UV presumably is in the back of your workstation, is it?
Yeah, it is. Yeah.
Okay. And that's in addition to the
Yeah.
disinfectant, so it's a double one. We know that other options are available, but it seems that the embryotoxic disinfectants the most obvious choice. Do you want to show the results, Sarima, and we'll move on to media?
Yeah, I've just shared it. So we've got about 75% of them obviously answered non-embryotoxic IVF disinfectant, which is what we would assume. And then, of course, as Davina mentioned as well, we've got some of them who have who also use UV light as a secondary as well with regards to the decontamination. And you can see from the ARC survey as well, it's quite obvious that most of us are doing the right thing, which is great. There's a little bit of mixture of others where we've got RNAs, DNAs free, and we've got a couple where we've got ethanol, but I'm assuming that they may be in a separate lab and somehow removing the effects of alcohol after. So we're going to move on to the next question, Dave, with regards to media.
Yeah, media. So of course, when you're, this is just like any other micromanipulation procedure, we're doing it outside the incubator, so we need to be wary of pH changes. I'm going to again make an assumption that you're either using a MOPS, HEPES, or HEPES and MOPS medium. Is that correct?
Yeah.
No one would advocate using a bicarbonate buffered medium. Is that a fair assumption? And I assume that's simply because over time, you know, the pH is drifting. It's a bit of a no-brainer, I know. So you can see on the poll that the same thing is true. So whether you use MOPS, HEPES, or MOPS, HEPES combination, that seems to be the routine. Nobody's confessing to using a bicarbonate medium. So
we've got one now.
Have we?
Yeah.
Okay. All right.
We've got one now.
Of course,
sorry, go on, Dave.
well, I was about to say, we know that people ICSI in a bicarbonate medium. It's not surprising that somebody might choose to biopsy in it. Yeah.
Yeah. So yeah, this is the result from the ARC survey that we've got, and we can see that thankfully a vast majority, you know, use the buffered media or the handling media. Of course, we do have some people who use culture media, but I'm assuming here that they do their pH mapping and temperature mapping as usual, which would probably give them an indication that if they need to change anything with their SOP, and also of course the KPIs with regards to blast development and so on. So moving on to the next part, embryo selection.
Yeah, and this is the one I think that has caused more interest and debate in advance of the of today's event.
Yeah.
So we first asked whether you have a protocol for embryo selection, and we've sort of touched on some of it already. So I'm coming back to the discussion about stage of expansion and so on. What do you guys think about, for example, biopsying a blastocyst that is below grade BB on a Gardner scale? So is either a C grade trophectoderm or a C grade inner cell mass? Who wants to go first? Katie, I'm looking at you.
I would. I have very much been converted. I think Shreem will understand because she was there as part of that conversion when I was going through it. My cutoff for freezing and transferring embryos has altered over the last 3 or 4 years. I regularly see embryos that are Gardner grade C, transferring creating pregnancies, being biopsied, being successfully biopsied and thawed and creating pregnancies. So I am very pro biopsying anything that's a Gardner 4cc. I would rather biopsy a Gardner 4cc than a Gardner 3AA. I will wait for that 3 to become a 4.
Okay, so interestingly, it's the stage of expansion that really dictates how you manage the biopsy. I'll come back to you because I want to follow up on how bad an embryo needs to be before you can't biopsy it. But Emma, you sound like you've got similar approach to Katie. Is there anything different?
No, I mean, We will, if the embryo is advanced enough and it's of a CC grade or above, then we will biopsy it. We might have a discussion if it looks like it's on the cusp of not being suitable. We'll keep it overnight till we see if it can hate this word, proliferate a little bit more and give you some more cells in the trove. But ultimately, we get, like, some of the times, a lot of the times our results come in, it's actually our more borderline embryos that are coming back as euploid. We've got really good pregnancy rates with our CCs. It doesn't affect our freeze thaw rates. And because we're waiting till they're really advanced, the biopsy is quite straightforward. So I think it's more about training and technical processes. But yeah, no issues at all, very similar to Katie.
And Davina, what's your approach? Do you have a cut-off for grading?
Yeah, we would biopsy C grades. I think sometimes a C grade, the cells can look better than other times where they might look a bit grainy, or you might be concerned about the integrity of the DNA. We always speak to our patients about the grades and counsel them and give them the option. Look, we've got an embryo that we think we can biopsy and we can get enough cells. You know, it may be at risk of being a no result or might not survive as well as another embryo, and give them the choice as well. We would only give them the choice if we feel that we can get enough cells from that embryo to get a result. And obviously we've got to be able to see where the inner cell mass is. So if it's a C grade, then obviously you want to be able to see a distinct inner cell mass, because you want to avoid that when you're biopsying. So yeah, we're open to doing C grades. It obviously looks, you know, we want to look at the texture of the cells as well as, but we would never rule it out, and always speak to the patients about, you know, the possibility of not getting a result or it not surviving as well.
Okay. And Sharon, are you broadly in agreement, or are you going to tell me you do something completely different?
No, very similar. Yeah, counsel the patients about the grading, and just if that one did come back as a no result, very unlikely that you'd be able to do a rebiopsy for them. That, you know, that embryo would not survive the process twice, but definitely worth giving it a go. Even if you might see the cells have lysed a little bit, if you can still see the nucleus, you still have a good chance of getting a result from that biopsy. So yeah, very similar to the group.
Okay, and when just picking up on the CC grade, does it matter whether that C grade is applicable to the trophectoderm or the inner cell mass, or does it not matter? As long as you feel that you can get a biopsy from it, you're comfortable whether that C grade applies to either. Is that a reasonable comment? So it sounds like you'll biopsy anything you possibly can.
Yeah, but you do want to realistically feel that embryo will survive the biopsy, a freeze, a thaw, you know, to really see the embryo has a future. I mean, you can biopsy anything, but, you know, you can pull cells out of any embryo, but you want to make sure that, you know, that embryo is going to survive and going to be a viable option for as a frozen embryo transfer for the patient.
Okay,
like
sorry.
Davina mentioned, you know, sometimes it might be super grainy or really fragmented. You know, maybe you need to leave that one behind, but another grade C might be okay. It's really dependent on the embryos.
Okay, so picking up on that then, perhaps Emma, I can ask you this. If you grade embryos as low as a CC, which is the lowest grade, but some of them are not biopsyable, how do you pass that information on to new biopsy practitioners? How do they know that a CC is the same grade as another CC, but one is biopsyable, if that's a word, and one you can't biopsy?
I think that is a word. I think it should be in the Oxford Dictionary because we use that quite a lot. So I think the training process here is just that actually the biopsy practitioners, when we're bringing them through the training, actually spend a lot of time watching us do the biopsy process. And it's just about teaching them the thought process of what CC we would attempt and what CC we won't. To be honest, I'm in the camp that if I can get cells from the embryo and it's of a quality where I think it's going to tolerate everything, I will biopsy it. So probably here we have less CCs that we won't do, if that makes sense. But I think if they were really stretched trophectoderm and I was worried about the amount of cells in the troph, then I would teach the trainees that we're just going to leave them overnight, because it will most likely go one way or the other. The embryo will either deteriorate overnight and has shown its fate of probably potentially not being viable, or it will proliferate and we will be able to give it a much better attempt in the morning. So our trainees spend a lot of time watching biopsy before they start attempting to do the training embryos.
So it's a watch and wait approach quite often that dictates whether you can and can't. So Davina, coming to you, if you've got these embryos of the same grade, and some you will biopsy based on graininess and so on, is there an issue with the way we grade embryos? I know that's slightly off subject, but do we need a slightly more elaborate grading system for people who biopsy these things?
Yeah, possibly. There's quite often there'll be an embryo that we all have a look at and decide between the biopsy practitioners whether we would give it a go or not. Just based on like texture of cells, I think that's important as well. That if they're looking a little bit like they might degenerate, then they're at risk of a no result if you're trying to tube those cells. Obviously, we'd still give it a go if we thought that, you know, there was an option there, and speak to the patient about that. But yeah, definitely it's subjective, isn't it? We all know that grading's subjective, but there are other things to grades other than saying, yeah, it's a C grade. Even a C grade inner cell mass, one can be quite clear that there's an inner cell mass there. One can be very flat, and there might be another area that you're unsure where the inner cell mass is, which I wouldn't attempt to biopsy because I'd need to clearly see where the inner cell mass was, and I'd culture for longer. So yeah, I think there's a lot more to it when you're biopsying than just, yeah, it's a C, let's do it. And that's when I think it's really important to speak to the patients as well, so that they're aware that there might be an embryo that's a no result, so that if it does come back as that they're prepared for that. But also patients sometimes just want closure, so they will want you to biopsy anything that you can, because they might be using PGTA as like a final attempt. So if they all come back aneuploid, then that gives them answers. So I think it's important to involve the patients as well.
Of course.
We have some, while we're on the CC topic, there are a couple of really good questions from our audience. Thank you for them. So one of them's asked us if the CCs were to come back as euploid and of course you transfer. This is obviously Emma mentioned about the CC, but I think we are in agreement that many of us do include CCs. So they're asking, what do you see a difference in pregnancy rate from these? And also if you've ever looked into your internal numbers with regards to whether the CCs which haven't been biopsied have a different outcome post-thaw than the ones that have been biopsied. So how do they thaw? Do they thaw well post-biopsy, the CCs and so on?
I don't have any problem storing CC embryos. I actually see more correlation with the implantation potential of the embryo on the day that it reached blastocyst stage, rather than the grade that it was at the time of the biopsy and freeze. So a 4cc embryo is still more likely, a euploid embryo on day 5 is still more likely to get you pregnant than a 4BB on day 7. So I think grade is important in how you, like what we've said about managing patient expectations, because there definitely is a decline in pregnancy implantation potential with a CC over an AA on day 5. But equally, from experience of my KPIs in the lab, I would say that my decline is more relationship to how the embryo got there and when it got there and when it got to that actual blastocyst stage. So we use a lot of the timings on the time lapse to see when embryos actually started cavitating, reaching blastocyst, and that seems to correlate quite nicely.
I think it's sorry to interrupt, Suru. I think it's really fascinating how in embryology timings seem to trump gradings and other observations time and time again. Embryos do things at specific times, or should do, and if they don't, there's always something less good about them. It's fascinating that it's always held true. Does anyone see anything different? Does anyone see day no difference between day 6 and day 5 or even day 7? Or are you all in agreement that timings seem critical?
Yeah.
It would be interesting to see day 4s, because I think some of the survey respondents did say day 4 as well. And from my experience as well, I think in some labs they do on day 4s. So ours post in SEM versus, I think it would be interesting to see how they. Okay.
Were you going to ask another question from the Q&A, Sharima, or shall we?
No, I think those were the main questions. There was one to do with hatching, but I think we can revisit if we have time for that. So we shall go on to the next one now.
Okay.
So we shall go on.
Oh, could I just?
Yeah, go on.
Yeah, no, fire away.
Okay, so with regards to the results from the ARC survey, very quickly, the good thing is most of us do have, it seems, that a criteria stated on our protocol, which is great practice. And as you can see from here again, and just to point out as well that, of course, this is multiple choice where multiple selections were allowed as well. But you can see that 90% of our 54 respondents have said that their preference or priority is trophectoderm grade, and then of course ICM and so on, which seems to be the consensus of the day, alongside the timing as well, which as Dave mentioned as well, which has held true. Any other comments from you, Dave, on the results from the ARCs?
Yeah, I'd like to ask the 4 panelists actually that I understand the first 5 maybe. I'm just wondering what their views are on how the patient history and their morphokinetic parameters alter the approach. I don't know who feels more keen to answer that. Sharon, I'll come to you.
Yeah.
How does that dictate how you manage the biopsy?
I mean, the patient demographic history, I mean, that might come into play. I think Davina mentioned that this might be the patient's last ever cycle. It might be a closure cycle before they move to donor eggs or something like that. So you might be more inclined to biopsy something for this particular patient just to get closure for them. I mean, morphokinetic parameters, I mean, a lot of places are using AI technology now as well. So if you're scoring a really high AI score, you might be more inclined to biopsy that embryo, even if the grading is suboptimal. It depends on what systems you have in place in your labs.
Yeah, absolutely. Any other comments from the team?
We don't
Davina?
really.
Sometimes if we've got an embryo that's, oh, sorry, go ahead.
I was just going to say that we don't really look at morphokinetics really. If it's an expanded blastocyst and it's suitable to biopsy, we might use that for if they had a few euploids, which one would we thaw first? But it wouldn't make a decision about what to biopsy.
So it's primarily led by what you see around the time of biopsy. Emma, you were about to add.
I was going to say that sometimes I'm almost sat on the fence a little bit about whether or not to biopsy an embryo, because it has made multiple contractions or collapsing episodes, and actually on occasion, because they are retracting so much, we have left them, and sometimes they do not continue to develop. So we do sometimes leave them overnight to make sure they're actually going to be viably able to expand and start to hatch. And on occasion, I think that's played into the patient's favour that we haven't biopsied an embryo that's not suitable. So not always, but definitely if we're seeing between sort of day 6 and day 7, if we're starting to see that multiple retraction in the morphokinetics, then we will probably leave it to let it play out a little bit.
Fabulous. Katie, any other observations? Or
We practice in a similar way to Davina, so we do use AI scoring, but we would only use it as a differentiator if we had 2 grade Cs that were both euploid. We would then pick whichever had the highest AI score.
Fantastic. Okay, so let's move on.
Just wanted to mention, Dave, that one of our participants mentioned with regards to, other criteria to include as insurance, which I think one of the things that you can see on the slide, whether, in some cases, insurance companies might fund a certain number of embryos. So, for example, here we know that Bupa apparently funds only for the first 8 embryos. And so that might be taken into consideration as well. For biopsy, deciding which embryos to biopsy.
Absolutely.
Okay, so we shall move on to the next one. And this is the number of embryos biopsies. So number of embryos per dish that you would use.
Yeah, so we've talked about, well, not really talked about it very much, but we touched on the choice of medium as a way of controlling pH, and you're all using some sort of buffered medium. What about the number of embryos per dish? Do you feel comfortable controlling conditions if you have more, or do you stick to one? Or what are the determinants of how many embryos you put in a dish? Emma, let's come to you first this time.
So this I have in my lab, I sort of call it negotiables and non-negotiables, in things that you absolutely have to do, like wear gloves and all of those things when we're doing certain things. And then the negotiables, I always allow the team to have some autonomy on how they feel based on their own practice and their own skill set, so that there's no rigidity in making them do something that they feel uncomfortable doing. So for example, I've been biopsying for about 17 years. I will very comfortably biopsy 4 embryos in a dish and have that process done in about 5 to 10 minutes. Equally, if someone that hasn't been biopsying that long does not feel that comfortable doing that many embryos, and that is their autonomy on their own technical capabilities. So generally here we do multiple embryos in a dish. I would say most of the girls do maximum of 3. I probably will push it to 4 just because of my own competency, but it's very much the same as ICSI for us, that if you don't feel comfortable doing multiple eggs in a well, then no one is making you do that. It's about technical competence.
Does anyone have a different approach?
No.
Yeah, we are very strictly 1 per dish, and that is a combination of managing pH and the time it takes to do the procedure, bearing in mind our SOPs fit all practitioners, so that could be someone that's just been signed off on clinical biopsy or someone that's been biopsying for decades. 1 per dish, and we also know that we're not picking up the wrong embryo. Even with a witness over your shoulder, you're eliminating that risk entirely, and so it makes for a more competent biopsy. Sometimes a bit uncomfortable when you've got 30 to do on a Saturday afternoon, but it's the only way to know that it's really that sample from that embryo.
And Sharon and Davina, any comments? Are you?
I would be very similar to Emma. So the embryologists that have been at this a long time and very slick at it are quite happy to put 4 in a dish. Standard would probably be 3, and then someone who's learning or just takes a little bit longer, maybe 1 to 2 per dish until they feel more confident and they could do it in a more timely manner. But it's all witnessed, so all drops are witnessed to dishes, so that there'll be no discrepancies with the biopsy that comes from each embryo that goes into each tube is witnessed throughout all the steps as well.
Okay, and Davina?
I'm an experienced practitioner and I do 2 in a dish maximum. Most of our other team are, just trained, so they would just do 1.
Okay.
I worry about having so many in a dish. If you knock the dish and the drops merge or anything, I'd want to make sure that when there's just 2 in a dish, there's always a drop in between. So yeah, I just think it's safer to do.
I think this just highlights that the people that have more than 1 in a dish, you presumably had the appropriate checks and measures to ensure traceability. That's a given.
Yeah.
That sort of risk mitigation with controlling temperature and pH, making sure you do the witnessing steps and have traceability, but also the risk in terms of knocking dishes and merging drops. You just need to factor that all in, I guess. I'm keen to move on because we haven't even got to the biopsy procedure yet, and I'm conscious of time. So we can see on the poll that 1, 2, and 3 embryos per dish is a normal thing.
And also from the ARC survey, it kind of mirrors that as well, Dave. You can see we've got most people doing either, I mean, the majority either 1 or 3, but yeah. So moving on to the biopsy technique then.
Biopsy technique. We took a decision in our training courses some time ago to only teach the flick technique. I know the results of the surveys. I'm not going to preempt it, but Sharon, let's come to you first. What technique do you favour, or indeed do you not have a preference?
We would do the flick technique. Yeah, that would be definitely our preferred method.
And is anyone different? Does anyone do anything different? You're all flicks. Okay, so you all prefer to do the mechanical flick technique. Would you all do laser shots before you flick, or do you judge it by the embryo? Emma, you're shaking. You're nodding, so I can see that. So Emma, you do the flick as well. Would you always laser, or would you judge by the embryo?
No, so I laser, but only ever 3 times. So I will bring my cells up my pipette, then make sure there's a narrowing. So sort of let some of them out, so you've got a fine narrowing point against the zona, because we haven't herniated. We've got the zona there. I would hit the gap junctions 3 times and then do the flick, like a bit like a perforation line in a paper book.
Yeah, very sort of classic laser and flick technique. Davina, anything different?
Yeah, we're the same, but probably just do 2 pulses, top and bottom usually.
Yeah, same.
Yeah, and Katie?
Yeah, same here. Something that's my practice has adapted over the last 3, 4, 5 years. I was a definite saw through with the laser previously, but yeah, adapted up to that, 3 shots on the gap junctions.
So are there any circumstances in which that needs to change? Would you ever have to resort to laser and stretch, or do you find that the laser and flick, if you're going to biopsy, it will work?
Yeah, I've always found a combination or one or the other is always sufficient. I've never had to go off protocol to try and complete a biopsy.
And is that the same for all 4 of you? I can see nods. Okay, I'll ask you a different question then. Who would use a different biopsy pipette for each embryo?
Only if I seen if the embryo was a bit sticky, or if I could see some cells stuck to the outside or the inside, I would change my biopsy needle. But I would change it probably every 3 to 4 embryos anyways. But I would only change it if I, one by one, if I seen some cells left behind, if I thought there was any risk of cross-contamination.
Okay, Katie, any different or?
No, again, the same. If I can see some loose cells stuck maybe to the inside of that biopsy pipette, I'd change it. But otherwise, we wash through the pipettes before moving on to the next embryo.
Okay, so well, that's interesting. So do you, when you set up your biopsy dishes and you've got your 2, 3, 4 embryos, however many it is in a dish, do you presume, 1, sorry, yes. Do you set up, specifically set up wash drops so that you can rinse the needle with, the biopsy pipette with, before you start the biopsy?
Yeah, so we'd have 2 drops, and the first would be a wash drop for the embryo, then moved over to the biopsy drop, and then we would reuse that wash drop to aspirate up and down with our holding and biopsy if we need to.
And Emma, something similar for you at Evewell?
Yeah, I'd have a wash drop for each embryo. So if I'm doing 3, then I'll have 6 drops in the dish, so that I've got a wash drop for each embryo. But I'm the same as Sharon. If I can see it on there, I'll change the pipette.
Okay, and Davina, something similar for you?
Yeah, we're the same. Rinse in between, but if you see any cells, change the pipette.
Do any of you use PVP for your biopsy pipette?
No.
Never have.
No.
No. Okay. It's a recurring question, and I know it's been asked in the on the Q&As that we get this repeatedly. This idea of. Sorry, Katie.
A recent change that we've made within the group was removing the PVP.
Okay.
Removing the PVP drop. So people that are training, yeah, they can start with the PVP drop, but then we start, as they become more confident, just stick with the buffer drop.
Yeah, I have to say again.
I trained with PVP.
Okay.
Yeah.
But you don't use it anymore, Emma?
No.
And what made you switch? What was the thing that made you think, right, well, we don't need the PVP?
I don't know, I think it was more historic. I started using PVP back in when we were doing day 3 biopsy, and then moved on. I think it was and then it just got phased out. So I don't remember it being a decision, if that makes sense. I just think it got phased out from the SOP in the lab that I was in at the time.
Okay.
And I just wanted to mention one of the comments that one of our participants have put in there on the chat, that they use up to 1 dish per 3 embryos, but they only do 1 embryo at a time. So that do the 1 biopsy, take the embryo cells out, and then put in another embryo, and then do a biopsy using the same dish. Anyone has any comments on that?
I like that technique myself. I think that's going to save with your plasticware and your media and your setup and waiting for dishes to be made. I think that's a really nice compromise myself.
Yeah, just I suppose the mixing up of cells or leftover cells in there could be the only thing, I suppose.
Well,
yeah, if you're crossing through the used drops.
Yeah, if you're sharing the used drops, yeah.
How do people feel about that? Because I know we've tended to, again, thinking of our training courses, we'd always say that you don't move embryos into previously used drops. What would your perception be? Would that be, as you say, Katie, is it a good compromise to reduce consumable use? I don't know whether we know what the risk is of cross-contamination between embryos. Would that?
I think the participant had suggested that if you imagine how Emma says she sets her dishes up, so 2, 2, 2, if she's doing 3 embryos, that from what I got from the question was that they would use 1 dish for 3 embryos, but only put 1 embryo in the first well biopsy, remove 1 embryo in row 2, and so still 1 at a time.
Okay, makes sense. So they're not reusable drops. They're yeah, got you.
And I guess also as long as when we're doing I think one of the other comments was as long as when we're doing multiple embryos per dish, we have to be careful that we're not mixing up between the cells as you were tubing as well. But then with the witnessing steps between, I suppose that can be avoided. So I'm going to quickly, in the interest of time, move on to the ARCS survey results very quickly. As we have discussed, it's pretty much in line with what everyone has said today. The laser and flick technique is the majority, which is good to see because mostly Dave has been going around training everyone. So that's a good thing, Dave. All right, so that is really that was the last question that we had for discussion, and I've just put in there some recommended reading with regards to the guidelines from the different bodies, from HFEA, ESHRE, and so on, and also, as you can see, not just biopsy but also transfer of embryos of different kinds and so on. I wonder, Dave, shall we probably take just one question? One last question.
If there's another question, or I can ask a question that I
no, that there's
to
some questions from our attendees. So one of the questions was if you have day 4 when you do day 4 hatching, and if it's like on the ICM that's hatching out, what are the techniques that you would, or what would you consider? Would you let it grow, or probably like fully hatch out and then do the biopsy, or do you want to do a second haul? how would you approach it?
I suppose I can answer that because I do the day 4 hatching. Yeah, you're gonna, as best you can, select a section of the zona. If you can see where the cluster of cells that might be your inner cell mass, you're obviously going to select away from those, but it's not always the case. Sometimes you come in the next morning and it is hatching by your inner cell mass. I would leave it for the day, see how it herniates. It's quite possible it'll just keep herniating, and you'll be able to grab cells from away from the inner cell mass anyways. I wouldn't make a completely separate second breach, and you can always leave it over till day 6, just to protect that inner cell mass, just to make sure you're biopsying the trabectoderm only.
Okay. Yeah, and I think one of the things that we wanted to check while we were doing the biopsy, how you decide in terms of, you know, when you're taking the cells in, do you guess how many cells you're taking in, 5 to 8, or you feel like confident that, you know, you've taken the right number of cells, or do you think you underestimate, or it's just a guess?
We, as much as possible, try to get sort of 5 to 8. But yes, when they're on top of each other, it is difficult to say exactly how many are there. But obviously, there is evidence that if you take more from a trabectoderm that's poor quality, that can affect implantation rate. So it's good to estimate, but you can't always be certain. But ideally, 5 would be ideal in our lab.
That nice balance of not having a no result, but not taking a big massive chunk either. You need to get that nice balance in between.
Well, thank you very much to all our KOLs, and also personal thanks to Katie, because Katie trained me on biopsy. So thank you, Katie, for joining us today. Of course, the rest of you as well. And Dave, what do you think? Shall we call it a day?
Yeah, we've managed to fill the hour. That's gone so quickly, and I've got
so quickly
quite a few other questions I could easily ask, but in the interest of time, I'd like to really thank Davina, Emma, Sharon and Katie for contributing to this and giving people the benefit of your expertise and experience. And I'll hand over to Emily perhaps for a final word.
Thank you, Dave. Well, I wanted to thank you and Sarima for running and organising the webinar today, and also to all of our special guests who came along and joined us and shared their expertise and input. I think there's so much more that you guys could have carried on talking about there for sure. And I know that Sarima and Dave are keen to run a follow-up to this webinar, either a second webinar or perhaps something at Fertility in Edinburgh, or maybe even both. So watch this space to find out what we do next. And if you're thinking to yourself, well, how can I find out what you're up to next? Well, you can sign up to our newsletter. And to do that, please just email our customer services team at customerserviceuk@coopersurgical.com. So I'd also like to thank our marketing manager, Tenna, who you can't see, but she's in the background running the webinar and promoting the webinar as well. And a massive thank you to all of the participants who turned up today, all of the delegates who've asked so many really good questions. Thank you very much for joining us. So if you're interested in genomics and you would like to know how PGT can play a role in treating patients to reduce the chance of miscarriage, then please do get in contact with us. We'd be delighted to invite you to our PGT testing lab in London, or bring in-clinic training workshops and education to you. So just contact your account manager if that's something of interest to you. So I shall finish there then, and just thank everybody again, and wish you all a very lovely rest of the day. Thank you. Goodbye.
Thanks,
Thank you.
everyone.
Bye.
Bye.